Welcome, everybody. My name's Michael Fine. I'm a writer and community organizer, a family doctor, and a public health guy, and president and board chair of Primary Care for All Americans. Thanks for joining us. We now have involved people from 40 states and the District of Columbia and something like 322 zip codes, who are building a movement and a healthcare system for the United States that's for people, not for profit, and starts by providing primary care to everyone in every American neighborhood and community. This is a big deal and something different than what we've done in health policy over many years, focusing on this notion of providing primary care to everyone as our first step forward to building a healthcare system that works. Our thanks to all the people who are volunteering from around the country to help. Our first state work group is starting up. We have a social media team of volunteers, a playbook writing team of volunteers, and volunteer editors and copywriters, video producers, social media people, and fundraisers, even a couple of volunteer trombone players. We need everyone. Please volunteer to help if you haven't already. I'm thrilled that we're going to hear tonight from Bryce Heinbaugh about community-owned health plans, about one more way communities can take care of everyone by bringing primary care to everyone. Please stay on the end. Please stay on at the end while our board joins Bryce for questions and discussions. We'll be talking about how you can bring primary care to everyone in your own neighborhood and community. It's now my great pleasure to introduce our moderator for the evening, Dr. Gabrielle Yaru, and to thank the Zoom Committee of Primary Care for All Americans, which organized this Zoom, to thank Bryce and all the presenters, and John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. Take it away, Dr. Yaru.
Thank you. Good evening, everyone. Thank you all for being a part of PC4AA, Primary Care for All Americans, where together we are building a movement to provide healthcare for all people. Healthcare for people, not for profit, in every neighborhood and community. Tonight, we are here to both teach and learn from each other. We encourage you to ask questions, put them in the chat, and we'll have time at the end to answer as many as possible after we hear from our keynote speaker, Bryce Heinbaugh. Bryce Heinbaugh is the CEO of Concierge Nurse Navigator and the founder of Ashtabula, Ohio Community-Owned Health Plan. Thank you for joining us, Bryce.
Thank you very much. I appreciate the opportunity to speak here tonight. And to be honest with you, it's a story of really any town or community in America. The opportunity is to anyone. You can replicate this simply. It's a matter of really just having a mindset of giving and certainly community. I want to give you, again, a quick background. Ashtabula, Ohio, Ashtabula County, Ohio, is about an hour east of Cleveland, far northeast corner of the state. We're a port town, Rust Belt town, considered one of the 32 counties in Ohio in the Appalachia region. And what I think most would find interesting is we are smack dab in the middle of a market where two large academic medical centers do business. Out of Cleveland and out of Pittsburgh. You guys can figure out who that is. But interestingly enough, the start of our community-owned health plan that we began to build here came in 2018, 2019, when our local inner city school began to see some of the highest healthcare costs in their history. And we began to get involved looking at some claims data and trends, and realizing that we had a real shortage on primary care. By the way, before I even go any further, I want to share with you, as Dr. Fine mentioned on the prep call, the cavalry's not coming from Washington to save us. And so this effort that we really have been pushing around, creating community-owned health plans and not Wall Street owned or, big health system or pharmaceutical owned health plans. We're trying to keep care local, open, so freedom to seek care, and anyone can have care, as well as independent. We're really big. Our Health Rosetta tribe that I'm a part of, we're really big with independent physicians and being able to work with provider groups that have autonomy to do really creative and innovative work, such as I'm going to explain. When we took over the city schools local plan here, we realized they were coming off again the highest cost healthcare year, 2019, in their history. And I actually ended up at the school board asking them to invest further, even go over and above what they just spent on healthcare, which was $10.5 million on 380 employees and their families. And I asked them to please consider investing in a program called direct primary care. No one knew what that was. But I had found a physician in town. He was the last freestanding primary care physician, independent, in the whole county. And he ended up selling his practice to the academic medical center in Ohio that I just was alluding to earlier. He had a 3-year contract, and at the close of that 3 years, they said, Doc, we really need your patient panel to jump to, you really need to be seeing more patients, and we're going to jump you to nearly 4,000 patients for your panel size. Dr. Lambros at that time, he said, gosh, I'm pushing 70 years old. This is, quite ridiculous, and I'm just not doing anyone any favors here. I can't provide proper patient care. So I sat down with him and said, here's the opportunity, Doc. We could start an independent practice locally called in a model called direct primary care, where it's a capitated rate. And we have a handful of employers interested in doing this. If I said to you, your panel size would drop down between 500 and 600, and I think I could get you there, full panel, 500 to 600 patients within 12 months, would you be willing to give us a try? That was the fall of 2019. We launched our first practice in 2020. And with the school, we ended up finding a few other local manufacturing companies. And all the while, Dr. Lambros said, I still want to see patients off the streets. If anyone wants to come and see and have care, we can do cash pricing. So we ended up launching direct primary care, very successful, immediately realizing the better we can do patient care, the less downstream hospital revenue that these local employers would be paying for. And so fast forwarding, again, looking at a Rust Belt town, as I told you, one of 32 Appalachian counties, not all physicians want to come here. It's a little hard to recruit docs, especially in Northeast Ohio winters. But I was able to reach out using the website dpcfrontier.org, found a physician nearby in Youngstown, Ohio, who had just started finally practicing. And I said, Doc, I have a need for another direct primary care doctor. I'd love to see you come to Ashtabula. Would you have any interest? And sure enough, he put in hung a shingle in Ashtabula and began to serve our local city municipality in DPC, again, value-based capitated monthly membership rate, where the employer just pays the membership for these patients. The last 24 months, I had an opportunity to serve on our local county board of health. And here in Ohio, and I'm going to put this plug out here, I wasn't prompted to, but our governor set aside some of the American Recovery dollars, $500 million Appalachian grant program to expand primary care in schools across Ohio that could, in fact, put on-site primary care physicians in our schools to serve underserved populations and expand not only to the children, but their families. And so I got kind of the behind the scenes movement on that. And I can tell you that in a county where we are, I think, one primary care physician for every 3,300 residents, we have a shortage, and that shortage has been growing for the past 10 years. I can say to you that the folks who are seeing this expansion of value-based primary care in our community are absolutely raving fans of it. And so from an employer perspective, we're saving claims dollars. We have a nurse navigation program that goes along with the physician. So if they do need to make referrals out to specialists, high quality specialists, imaging labs, et cetera, they can work with our nurse care navigator. And what I don't want to leave out as well is we found our last standing community pharmacist. We embedded our community pharmacist with the direct primary care doctor and the nurse navigator. And I know this is advanced language for some, but the model is really recognized right now as called advanced primary care. So we have a patient-centric independent care team that really helps these patients get the best care they can. And if we do need to send them onward for specialty care or complex care, we have the ability to do so. And so I hope that in this short amount of time, and I know we're going to have a Q&A opportunity, I hope to answer some more questions, but I want to reiterate the future of healthcare, we believe strongly, is centered around primary care and the future of it being local, open, and independent. I just told Dr. Fine a moment ago, just last month, I went to a local junior high in our county and tried to change mindsets. I just don't think young kids are being encouraged to go into medicine per se in these underserved populations. Folks aren't talking to them about it. There are bright children that can get there. But I went specifically, I had asked the administration, could I speak to some junior high kids on the lunch breaks around going into being family doctors? And I can tell you that from that experience, felt really great about it. I had a couple kids follow up with me. But we just need to encourage more and more people, especially going back to the communities in which they grew up, to serve in this capacity. It's a very, obviously, I understand it's not the highest paying position in medicine, but the impact that physicians can make in family medicine, I think, goes much further than the money that can be made. And so the balance with physicians in this model of direct primary care goes back to kind of serving the quadruple aim. Physicians are satisfied. They're not worrying about paperwork and insurance company, the PAs, and all of this business of healthcare. They have more meaningful work, and so we're real excited to say that we have two practicing independent direct primary care doctors here in this community. I can promise you we're seeking more as we're moving the needle. And every community that we do business in, and we are coast to coast. I mean, this example is a snippet of the work we do here in Ashtabula, Ohio, but I think it's the reality that it can be done in any community. But we're really excited to be a part of the movement here. We're excited to be, sharing this case study with you guys. And at some point here, while we're going through the rest of it, I'll try to share a website link if you'd like to see this case study. It was published by our local Cleveland ABC News affiliate. We had a great segment that you can see what this model has done for our local teachers and their families and school bus drivers, speaking about the model from a third party, not us. We didn't pay for it. They knocked on our door and said, hey, tell us about what you're doing here and the meaning behind it. So I'll share that in the comments link here in a moment. So thank you.
Thank you so much, Bryce. Do you have a question for Bryce? Please post it in the chat and we will answer them in a moment. While you submit your questions, let me introduce Dr. Aliyah Shafi, my colleague at Jamaica Hospital Medical Center, who will remind us why this work is so important to us.
Hi, everyone. Making sure everyone in all our communities has healthcare and health insurance they need to pay for primary care is a critical challenge. Making sure that health insurance works to support primary care is also important. And making sure every neighborhood and community has great primary care clinicians and practices that are enough doctors to see everyone who is sick the same day is even more important. We have to nurture the young people in our communities so they become the nurses and the doctors we desperately, desperately need. We need to quadruple the number of medical students from our communities so we have the health professionals we need from those communities. That ultimately means we have to stand shoulder to shoulder with our students and residents and change things so young people from our communities aren't pushed out of the healthcare system by huge loans or, quite frankly, a training system that asks for superhuman effort. So we have to create one in which provides adequate support for them.
When we say primary care for all, we mean everyone. When everyone has primary care and when communities can get primary care from doctors and nurses who are part of the communities they serve, the health of our nation improves as our communities grow stronger. Here's what primary care for all Americans is doing today and what we need your help with. We're writing a resource guide and playbooks so communities, states, and national level policy members have the information they need to provide primary care to everyone at their fingertips. We are building the training process so work groups in our first 3 or 4 communities will be able to help those communities join Little Scituate, Rhode Island, become the first places in the US where everyone has primary care. We are launching our first state work groups to advocate for training more nurses and doctors from our communities who will return to their communities to practice. Our movement starts with you. By joining us tonight, by learning about how communities can provide primary care to everyone, and by bringing someone new each week. We'll build this movement together, but we also need you to join a work group. So please click volunteer. So please click the volunteer button in the contact us section on our website to tell us how you can help. Together, we can make sure that everyone in the United States receives equal health care and gets equal health, regardless of where they live, how much they earn, what community they come from, or what they look like. Coming together for this teach and learning, we are that much closer to bringing primary care to everyone. Together, we can build a healthcare system that is for people, not for profit. And yes, we can provide primary care to all Americans in every American neighborhood and community. Now, let's get to your questions. Brian, can you share some of the questions from the audience?
Thank you very much. Thank you, Bryce, for this really informative talk. I am sure that this was full of lots of information that is new to a lot of people in our audience. Those of you in the audience, feel free to post your questions in the chat. Several of you have done that already, so thank you very much for that. And if you are more comfortable doing so, you can just digitally raise your hand and we may call on you and you can ask your question directly. So first of all, can you tell us about the financial impact of this plan?
Sure.
Overall, whatever is most interesting to you about that impact.
Yeah. So it's hard to put a thumb on the exact savings of the direct primary care practice alone by installing the program. I'll share with you a couple of quick things. First off, in the first 2 years of basically doing this advanced primary care program, along with a few other solutions, we actually put a savings back into Ashtabula City Schools right around $5 million. And that was in the first 2 years. Since then, I believe that the total was right around $10 million. So 2020 and through really 12/31 of this past year, significant dollars. Those dollars stayed in the coffers of the city schools, and they're able to obviously redirect some of those dollars into wages and in other programs that we've put into place for them in the employee benefit space. For DPC, for example, I did pull just our last quarterly report that we provided to the city school district. In that quarterly report, our physician had for the schools 200 acute visits, somewhere around 30 redirected, meaning avoided urgent care visits, and avoided right around 4 emergency room visits. each and every one of those examples I gave you would have otherwise resulted in a downstream fee-for-service, more expensive care setting. And the direct primary care physician did those at no additional cost other than the monthly fee that is paid by the employer. I hopefully give you some flavor and understanding of the savings that you can see when you're avoiding all the urgent care, acute visits, and emergency rooms.
Yeah, thank you. So who assumes the financial risk for patients who do have severe illnesses or things that need to take them beyond the primary care environment? That's a question from Michael.
Yep. So great question. So whether this is an individual, let's say I'm a self-employed person with a family of 4 that I need to still have insurance of some sort. A lot of times what we see, whether, in that case, folks will still buy insurance or a ministry share plan per se for the high risk or the high cost things that could happen. But all the while they're seeking the direct primary care physician for most all of their care. In the case of the schools, in case of the city, large employers, they are on the health plan of those employers, but the employers incentivize the employees and their families to utilize this type of model, direct primary care. They incentivize because it becomes no cost and it's unlimited usage for those families. So no copays, no deductibles, no out-of-pocket cost to the patients.
Okay, great. Thank you.
Yep.
Larry, you had a question? You want to ask it?
Hey, Bryce, it's good to see you again.
Hi, Larry.
So you introduced me to 5 of your Health Rosetta colleagues, excuse me, who are very interested in replicating this model in other communities across the U.S. I see the potential for a real grassroots movement where community-owned health plans can pop up all over the place. I'm wondering if you can comment from your perspective. Your colleagues, I think Dave Chase was on the call here as well. Do you see this having someone like yourself who knows how to speak to employers so that they can see the value and benefit of this model is very powerful? What's your sense of the potential for a tremendous grassroots movement here?
Yes, I really believe that this can be replicated. It does take, as I shared in the past, it does take an influencer. So, maybe you are a physician in your community, you know a school board member, or a CEO, or maybe they're a patient, one of the C-suite of a local company. You've got to have some influence. An employee benefit advisor, a consultant, we like to say a community-owned health plan architect. We pull all of these parts and pieces together. It goes, again, without saying, I'd love to protect community pharmacists as well. But if you take the mindset that as a team, you can approach employers, a school district, a county government. This is, Health Rosetta, our organization that really has helped me learn and understand how to do this. We have a playbook for it. It's really, I just call it a recipe, and we can replicate it just about anywhere we go. I fortunate enough, just for example, this past December, we did this in outside of Orlando, in direct primary care is at the Staple, the nurse navigator, a community pharmacist. I mean, that's a big city, metropolitan Orlando. We have this going in Orange County, California. And believe it or not, rural West Virginia. We were elated. It took me 2 years to be able to launch the program, but we launched with a primary care physician who got sick and tired of being sick and tired and working for insurance companies per se. Went out on his own, and I said, "Hey, I would love to change your mindset and your practice, and I can help you do this in the community that you grew up in, and you can give back in this manner." And so we're seeing it Larry, I don't go into a community and have any concerns that we cannot do it. It's really, we've got the parts, pieces, and people. It's just a matter of the collaboration.
Thanks.
Yeah.
Thanks, Larry. All right, I think we have time for one more question, and I'm going to combine some questions about panel size. You talked about somebody having 4,000 in their panel. Seems like too much. Ideal sounds like 500, 600. And I'm going to combine that with a question about workforce. If we have not enough primary care doctors, and then we take them from taking care of 4,000 patients to 600, what, other than the obvious mathematical answer, what is the effect on workforce, and what can we do about it? And is this going to help with the workforce problem?
Yeah, that's a great question. I'm going to say two things to answer this. First off, we already have a shortage. We know that, and it's getting worse. It's again why we have to do such a great job in influencing and attracting more family medicine docs to this entire model, and the really saving healthcare and health outcomes. As I mentioned to you, we did not have an independent primary care physician in Ashtabula County for a number of years. This model allowed me to recruit two, and no one said, no one believed that I could do it, and went out there and found the right folks who, were able to see the light and say, yes, this sounds great, and I want to do this. At a lower panel size compared to even 2,000 patients, the quality of care that is able to be done, I want to say to you, it's exponentially better. And I'll give you a quick example. In just the last quarter, the DPC physician that we have serving the city of Ashtabula and the schools here, not a giant population, but maybe around, I'm not certain exactly his enrollment numbers, but he identified three thyroid cancers in the last quarter, that all three of those patients had previously seen their employed doctor, primary care doctor, in the last 12 months, and there was no talk, detection, nothing. And I just want to say, he's really, able to take the time with the patient, 30-minute or 60-minute visits. He follows up. If you have come in for an acute illness, he has the time to follow up. He calls or texts the patient the next day, says, hey, how's your child doing? How are you doing? And I just want to say that the impact, Dr. Peter Attea's book, Outrun, and I think about the term health span, and really just being able to help people not necessarily live longer, but have more years without disease or disability. I just truly believe a smaller patient panel will have that type of an effect on patients. But we've got to do a great job, grassroots, to spread the word around this great model and expanding primary care in every community, which I love what you guys are doing here. I mean, it goes without saying, it's the only way we're going to be able to infill with more doc.
Well, great. Thank you very much. I'm sorry for asking you a question at the end there that could have been its own webinar all by itself. That's all we have time for right now. If you have more questions, there will be time after we say goodnight. We're going to stay on until about 9:30 for those of you who have more questions. So thank you for sharing your insights, and take it away, Dr. Fine.
Look, movement building is a crazy huge undertaking. We've got about 10 things we have to do at once. We're trying to start work groups in 25 local communities over the next few years, giving them the opportunity to look at community-owned health plans, to look at the Situate Health Plan model, to look at getting people on the boards of health centers and hospitals and turning the ship in that way. It's just, and at the same time, we've got to start putting together, and are starting to put together, state work groups to start working with state government, so that we start increasing the number of primary care clinicians we're training, because we got to address workforce if we're going to make a healthcare system that's for people, not for profit, and provides primary care to everybody in every community. Clearly, the folks with something to sell, who are taking something like $2 trillion a year out of our communities, aren't going to stop draining our communities just because we say pretty please. That's why we have to get together. Healthcare impacts all of us. Let's reach out to colleagues, families, and friends, and together build this movement and use healthcare as a way to bring the nation together. This isn't a Republican thing. As I've said before, this isn't a Democratic thing. It's an American thing. The cost of healthcare affects every single American community. The ability of Americans to be healthy and participate in their families and communities, that affects democracy. We're the public in public health. And if we're going to make public health matter, we've got to work together. And if there's and when we work together, there's nothing we can't do. So let's get started. The time's now.
Thank you. We are also working on our Zooms being captioned in Spanish. We have Nelly to explain more. Nelly? Okay. So as we work on that, we encourage everyone to bring someone new to our next Zoom on April 2nd, when we'll do our first state-by-state breakouts. Register on our website, www.primarycareforallamericans.org. And while you're there, click volunteer in the Contact Us section on the website to tell us how you'd like to be an active part of our movement. And please click donate to support our work together with the contribution. Every little bit helps. Once again, we need and appreciate every single one of you for helping us our movement across the nation in order to get the change we need and you deserve. Join us again in 2 weeks. Bring one more person each time. Better yet, bring 3 or 4. Tell everyone. Healthcare for people, not for profit. Primary care for all Americans.
Please take a minute to complete our survey, which I've just posted in the chat for you. That will really help us to improve by hearing what you all think of tonight's teach-in, learn-in. We want to hear from you, and we thank you. If you'd like to talk with members of our leadership team, or if you have more questions for Bryce, please stay on our call, and board members will stay on to hear your feedback and help us grow as a community.
Thank you, everyone. See you on April 2nd.
Questions? Bryce, why don't I ask a question to get us started?
And if I can mention, I just saw the one question here just about if an employer is paying both for a healthcare plan and direct primary care fees, how is a savings generated? And the quick answer, I think Larry I just see that he mentioned it, but the quick answer to it is if we can do proper primary care, there are less needs for additional downstream services. The RVU, the demand for more services and more tests and referrals, that really puts the brakes on a lot of that. So you have less downstream costs, and the claims costs going down will actually create a savings and an ROI in the investment on direct primary care. It really goes without saying. It's a big savings, and the patient, most importantly, the patient wins.
Questions from others?
Can I add into that as somebody who's really thought along this line for a long time in a rural community? What can you offer that 70-year-old primary care doctor who's, the 70-year-old doesn't have their student loans? If I'm trying to get somebody who has student loans to
Yeah.
pay back, what kind of figures am I able to
Yeah.
offer them about this?
Yeah, that's a great question. So, and I'm happy to answer it. For example, that physician in less than 12 months, he went from 0 patients. And by the way, I want to share with you what a great community and tribe DPC docs across the country
Yeah.
have become, helping each other.
Right.
Yep. So I had a physician in Tampa, Florida, Dr. Eric Kroll. When I first was really trying to learn about this, I met Eric at the Hint Summit, which was with Health Rosetta out in San Francisco, and he said, Bryce, if you find a doctor who's willing to do this, I'll help you. I'll share all my tricks of the trade, and I credit him because he did. I followed up with him, and he said, Bryce, I'll show you everything. So we went from 0 patients to just over 500 for this 70-year-old physician, and the capitated rate here in Northeast Ohio that I was able to help him negotiate was $75 per adult per month. And we did have some children, but even if you just said, okay, 500 patients at $75, that's a revenue of $450,000 a year with no insurance paperwork, no documentation other than his own little EMR that he was utilizing, no dealing with PAs. He had one part-time staff member, an office manager. Everything else was automated in Spruce telemedicine software. So also HIPAA secure text messaging, the operations software, the practice management software did the billing. And quite honestly, he said, I just can't believe it. All the time that I have now and how simple this has become. So even after overhead and expenses, overhead and recovery, he still makes a great living. He gets his life back. And quite honestly, I said, Doc, I right into the sunset, but I hope you enjoy the last few years. And he said, Bryce, this is so satisfying. So, if you get up to 600 patients, hey, you're talking over $500,000 a year in revenue with very little overhead.
Dr. Bagley.
Thank you.
I'm not sure I should be speaking up here, but many of you know I'm a past president of the American Academy of Family Physicians, which forces me to have a more global view than some. And I have always sort of admired the direct primary care approach and totally understand that the benefit accrues to those family physicians who take on a panel size that's totally manageable. Thank you very much for that. And for those people who can afford to pay for that, thank you very much. But the facts are that we don't have the capacity to take care of our entire nation under this model. And it promotes a model that's only available to the well-to-do. And it excludes those who can't afford to engage in this model. So although I admire how it works, I worked for 28 years in direct primary care in a group practice. I get it. I've been there, done that, struggled with it, had all of the problems that most of us face as family physicians. But I want you to try to put this in the context of how we can fix our nation's health problems and health availability and health access. So yes, it's a great model for those who can engage in it. Thanks for listening to me.
Bruce, let me jump in for primary care for all Americans, and then I'm going to ask Bryce and maybe Dave Chase to respond.
Sure.
But from our perspective, the challenge is workforce, and workforce.
Yes.
And that's a challenge even before we talk about reducing panel size. we're clearly, burning out our colleagues, asking them to do the work of 3 and 4 people, because we haven't invested in workforce as a nation before. And so the approach that we're taking at Primary Care for All Americans, is to try to walk on 2 or 3 or 4 feet at once. One is to really put together state work groups to really get states to look at workforce, and really ramp up the number of primary care folks we're producing, like quadruple the number of primary care folks we're producing. And that's going to be necessary, whether it's necessary today, let alone necessary under a direct primary care model. We're not making the argument at Primary Care for All Americans that everybody should do direct primary care. But this is one model that has worked for some communities. We think community health centers will work for some places. We think other approaches will work in other places. But in order to fix this, we need to build really a social movement big enough to be able to take on these very complicated, different issues at once: workforce, organization, panel size. There are a bunch of things we need to do at the same time. And unless we engage and start, then we're just going to sink deeper and deeper in. So let me then pause and turn it over to Bryce, and maybe Dave can join in as we discuss this.
Yeah, great question, by the way, Dr. Bagley. This is a great one. The school district is the most white collar client that we serve. The rest of them, all of them, are working middle class or working poor. And just in Ashtabula County alone, at a chemical company and a chroming company, both of those populations were what we would call functionally uninsured. High deductibles, high out-of-pocket costs, and people would avoid care at all costs unless they're, emergency, a heart attack, something like that, cancer. And so I will say that one of our clients is the largest independently owned sawmill in the United States in West Virginia. The average worker makes in between $18 and $22 an hour. We have a doctor going on site to a sawmill in muck boots, almost like a veterinarian doing farm calls. I mean, it's that, that's the environment.
Yeah.
But these folks able to get the care that they otherwise could not have or afforded. It has really been a big help to those populations. I would like to see more and more, if there was some governmental funding that would, kind of like the Medicare, Medicare Advantage model, where there's some risk involved, but if you can manage a population and the government's helping pay those costs, I think there's a reward for the physician, the patient. But I do see this big for us is more in the blue collar work arrangement. Dave Chase, do you want to add anything to that?
Thank you for that. I hope that actually plays out. In the early stages of this, that didn't seem to be the way it was working out.
Yeah, I mean, I'd echo some of what Bryce said. I mean, we deeply care about the working class, working poor. If you look at nationwide, which, Bryce is a key part of our nationwide movement, the heart and soul of what we focus in on is United Way calls them ALICE, asset limited income constrained employed. They're the people who really need our help. I put into the chat a couple things. One is a longer answer to how it's not an easy thing to address, obviously, as you all know, to address the primary care shortage. There's a bunch of factors that caused it. There's a bunch of things that we think solve it. Rushika was on earlier. I saw his model with my parents, Medicare population, but the case study I put in the chat with the employer that has saved cumulatively $560 million, definitely primary care physicians, very important in that model. But equally important are the PA, the dietitian, the health coach, the chiropractor, the pharmacist. They are all part of a fully actualized primary care team. everybody practicing the top of their license. And you don't have primary care docs that are, spending 2 hours on insurance bureaucracy for every 1 hour of patient time. So there's a lot of things. Again, there's no one silver bullet, but a bunch of things caused it. A bunch of things will solve it. And I think the fact that we actually have a primary care model that's appealing and not run off internists who wanted to go into primary care, they've specialized in some of the other things I addressed there. So very important concerns, but things have evolved a lot.
Dr. Connard.
Place where
Scott, we can't hear you.
Yeah, your audio just is breaking up. Not
Scott,
yet.
why don't you look at your audio and we'll go on to Larry and come back to you. Larry.
So I want to make a comment. I've been putting things in the chat room here. I've been very involved with the DPC movement since its very beginning. I found it back in 2008 before it had a name. And what has struck me about DPC docs, these are mostly family physicians who value taking care of everybody and actually have, for the most part, a sweet spot for the poor and the underserved. They are different, and I don't mean to offend people here, but it's the internists who are choosing concierge medicine with a high administrative fee at the beginning of the year, and they still bill, the insurance company for their the care they deliver throughout the year. So the DPC model is, I think, uniquely aligned with the interests of the working class and the poor. And of course, if wealthy people want to pay the monthly membership fee, if they're smart enough to value good and accessible primary care, then, God bless them that they do that. In many cases, what I've seen is that it's the employers who pay the employees' monthly membership fee. And they do that because the model is so good in terms of return on investment that even paying for the regular insurance and the DPC monthly fee is much cheaper than doing it the other way. So I made a comment in here that I think a lot of people think that DPC, they're taking care of the wealthy. And that's just not the case, because it's family physicians who are doing this, and they don't sell out and just go for the wealthy or well-to-do in their communities.
Margaret.
I'm a little more concerned with the community side of things. You talked about problems with the high costs in the school system and direct primary care is the solution, but who are the decision makers that you had to talk to? How did you, did you need any money? It seems to me that there was a lot of work that had to go on in terms of working with the community to get them to agree to this model.
It's a great question. One in which I'll tell you, it is not for the weak or faint at heart. They really require some influence. That we got into the labor unions, for example, the schools. We got certified and classified. So your teachers, your bus drivers, cafeteria workers. I went right to the head of those unions and asked to, either have a meeting or educational, segment. And some of the case studies that Dave Chase has shared, even I educated around those to try to change mindsets around changing healthcare. And obviously their labor agreements can be very strict. And so what we did was we went with the concept of, we're not changing your care, we're actually adding more value. And so we never got any pushback when we said, we're adding more to your health plan, and they're voluntary options that if you'd like the idea of this, sign up, and it's not going to cost you anything more. So we did that. And then we went to the city, and I went into the firefighters, the police union, sanitation, and we did the same idea, mindset shift. And sure enough, they all bought in, and they bought in heavy. And so I think it's influencing the end users and those, labor agreements, but it's also, city council, school boards. I did go to the school board president and sat her down at first meeting. I said, I'd love to have a coffee with you. I'd like to share with you that something innovative, and other public schools across the country have done it. And so it was a multi-angle approach.
Okay, so it wasn't necessarily the school system coming to you with a problem of high costs. It was you saying, there's high costs here, I can give you a solution.
The CFO or treasurer of the school district did approach me and said, we have a problem. Can you help us? That's how it first started. Yep.
And if I can just chime in one thing on the financial side, there's definitely that pull from the employers, but an important opportunity, I think, for all of us to understand is every year there is a river of healthcare money that flows through our communities. And Dr. Fine's spoken about the amount of waste in his books that's well documented. The headwaters of that river of healthcare money usually are the community itself. The problem is much of that money is getting diverted to Wall Street rather than being like the water cycle. So a lot of what we do is say, hey, we don't need to have 73 cents of overhead. Clinicians are only getting 27 cents of every dollar ostensibly spent on healthcare. If we just redirect that money to the things that actually drive health and well-being, there's more than enough money to not only fund a world-class healthcare system, but the dollars to restore funding to actually what drives 80% of health outcomes, which is really, that's the purpose of our organization and movement. I talk about is take healthcare waste, turn it into fertilizer for restoring the American dream. Like that's what's happening in places like Ashtabula.
Yeah, well, I thanks, David. And one thing, some of the savings, for example, after the first year, we were able to put some of the savings back, and we took the community pharmacist in town and said, for anyone that fills their prescriptions at our local community pharmacy, those drug costs will be zero. There's no copay. And so obviously the school had to agree to that. The labor unions would not argue it. And so those dollars now we're making sure they're not going to CVS, Walgreens, and others, but they're staying right in town here with the gal who runs the pharmacy with her 4 other pharmacists and sponsors our little league teams. It's lovely.
Bryce, I have a quick question. Have you done any thinking about how community-owned health plans could create scholarship programs for students from the communities that they exist in to send the students from those communities to health professional school and obligate them to come back and practice in their own communities? And if so, how would you capitalize that?
I think it's a great idea. It is not out of reach. The employers that we have saved these dollars for, they have come to me and said, what should we do with the savings? Like what's the best way to spend these extra dollars? It's really just making a means to make that happen. And I chair a foundation locally that we just give a couple of scholarships a year to recent grads. I could see myself going to the board of the foundation and saying, let's set this up specifically a scholarship program for folks wanting to go into family medicine. And I happen to have the influence with these employers that say, help me fund this. It's within reach. I just haven't necessarily processed it.
So you think it could be funded locally? It sounds like.
It very well could be. Sure. Yep.
Larry.
Well, a related thing is, I mentioned Rosen Hotels earlier. They haven't specifically done that for family medicine, which I think is a great opportunity. What they've done, however, is, this $560 million and growing that they've saved over 30 years by having a great primary care model. They've taken just 5% of that and invested in kids and education. They funded hundreds of college educations fully for the community. And then because they've saved so much money as an employer, they pay for their employees and their employees' kids' college education. Like that's the kind of scale money that's available if you don't squander it on, I always say healthcare is not expensive, right? To my earlier point, what's expensive is profiteering, price gouging, administrative bloat, fraud, and some inappropriate care. Just opt out of that, and we got more than enough money.
And the way to opt out of it is to make sure everybody has a primary care clinician who matters. Dr. Connor, you want to try again?
Yes, I'd like to. Can you hear me now?
We can hear you better. Great.
Okay. So first of all, I just want to answer David Power. He put a question in that, Bryce, I know you would agree. The answer to the question of is there a place for nurses, social workers, dietitians? The answer is absolutely yes. I have a bias around data. Bryce, you said, the administrative burdens goes down a lot. As a person who looks at population health, I hope that somewhere in there's a claim or there's some way to communicate back who's receiving care and who's not in primary care for the employers. So I just say that kind of for those of you who are thinking about this. But my main comment is, are we at a place, Bryce, where we can rinse, repeat, and walk this across the country? Right now, the Fortune 500 through the Health Transformation Alliance, they've got 350,000 employees that they will fund. These Fortune 500 companies will 100% fund direct primary care, advanced primary care. It's the preferred term from my perspective, but it doesn't matter. If they can find advanced primary care clinicians in their environment. So if anybody has an advanced or direct primary care practice that wants patients, there's a lot of them looking for doctors. And for me, that's a big part of the statement. The stake is in the ground. We're going to support this. Now, doctors, please open your doors to these patients and sign up. And that's a big part of us getting this going.
At the same time, we have to start thinking about opening medical and nursing schools. It's not going to happen by itself. Basically, we're going to have to do it, which is the scary thing. But it ain't going to happen by itself.
It's not going to happen by itself. But on the other hand, I will tell you, our healthcare education system is so broken because you still have the academic nerds that are getting in, and a lot of the people who would be fantastic patient communicators and great caring healers don't have the GPA or they're not on the top of these test taking. And so we've got to change the model at the same time. We've got to have a model that takes people in who want to have relationships and care for people, not just want to, itch their academic scratch, if you will.
Hear, hear. Everybody should know that there are about 66,000 Americans who apply to go to medical school every year. About 22,000 get in. And I'll bet in order to apply and survive darn organic chemistry, that 62,000 are able to go and be good docs. And what we have failed to do is understand we need to create training opportunities for the 40,000 or so who aren't getting to medical school. It's not going to change by itself. We're going to have to change it. Larry, and then we're out of time. Larry, you're still muted.
Yeah.
Among those 40,000, there are a significant percentage who are very good test takers. They just weren't at the very top of the heap. And they end up going to places like Ross and St. George's and some, not all, but some of the other Caribbean offshore medical schools. I've seen the data on their performance. These are determined people who want to be a doctor. Many of them want to be primary care. They've just been shut out of our system. So the people are out there. We have to look at the admissions process, which, Bruce, if you have any influence with AAFP, please tell them that the focus has to be on admissions. Getting the right people in will produce the right people coming out.
And quadrupling the number of people we're training, in my view, and also quadrupling the number of nursing students and places for nursing students. I've seen this happen in Rhode Island, where students from our communities who ought to be in nursing school somehow can't get in. It's a heartbreak. Bryce, you want to have a closing word? You deserve it.
Yeah, Yep, my last thing. Thank you all again once again for having me. But Pat, I see the last comment on my feed here is, why don't all employers jump on board since this has been proven for productivity, health outcomes, and big savings? Unfortunately, one decision maker can just say no to it. We just spoke to a university down in Texas, about 60,000 employees, I think. The human resource director said, "Oh, but I just love my acupuncture that they cover here, and we don't really need to change anything." And so, share with that. But the Consolidated Appropriations Act, I believe strongly that we will begin to challenge employers to looking for solutions like this that create better care, lower costs, and certainly better health outcomes. So I'll end with that. The movement's happening. We just need to keep on trucking.
Keep on trucking. We need everybody to come back in 2 weeks and bring 2 or 3 more people. Movements don't happen by themselves either. We got to build it. And the way we build it is to bring people in. Each of us by ourselves, making a couple of phone calls, sending a couple of emails, and building our numbers, because that's the way this is going to work. Thank you all
Right.
for being here tonight.
Yeah.
You've been amazing. Thanks to Bryce, who was extra amazing. This is a fundamentally important model, one of a number of approaches that we can bring to the table to make sure that we bring primary care to every single American, everyone in every neighborhood and community all across the country. Thank you all.